Thanks everyone for coming. Welcome. It's my pleasure to introduce today our speaker, Dr. Jifang Zhou. He is a second-year PhD student in our department. He has a world of history and a lot of experience behind him. He's a physician from China. He received his medical degree in Shanghai. He also spent between 2011 and 2014 working for Doctors Without Borders as a medical officer and team leader in the South Sudan and the DRC, and also in South Africa. Before coming to us here at UIC, he was at the University of Michigan, and he did his MPH in health policy and healthcare administration. And he also has a certificate in science, technology, and public policy. So he has a lot of experience. Today he's going to talk about something he's really passionate about, bone marrow transplant and hematology oncology. What he's bringing to our department now is a lot of experience with advanced analytics, and I think he's going to talk about some new methods he's been working on today. So welcome, Jifang.
Yeah. Thank you very much. Thank you for the kind words. Thank you for having me. Very happy to share some of my findings working with Greg, but also with some other collaborators across UI Health. So today my presentation is on survival care. I name it the long and winning road because survivorship is not easy. I will tell you more. This is the agenda of today's presentation. I will start with a self-introduction. It's going to be very brief. And then I will talk about the history and the overview of bone marrow transplantation, two studies, then the Q&A. So this is me. As Brad has introduced, I complete my medical training in Shanghai. It was a French-speaking medical program, so I learned French and get an exchange program, go to Paris, spend some of my time working the bone marrow transplantation, and then I kind of specialized in bone marrow transplantation in my residency training. I went to Africa because I was not happy with cancer care in China, so I spent some time in Congo, in DRC, in South Sudan, South Africa. So I can't do hematology oncology there because the infrastructure was unimaginable. So I kind of switched my interest into tropical disease, HIV, and tuberculosis. I spent 2 years in South Africa working for HIV and disease and drug-resistant TB program. From there, I was promoted as a program manager, the technical referent, and also the medical expert. I went to University of Michigan to complete my MPH training, mostly in global health and health policy, because I want to know more about health services research. And from there, I get into contact with HEOR. So I decided to apply for the PhD program, and here I am. I'm very happy to be with you, and I think the experience and trainings are invaluable here. This was me in 2009, and I was in Paris working the world's second largest bone marrow transplant center. The patient was an incredible, very passionate woman who suffered from autoimmune disease, a very rare disease that can cause damage to red blood cells. She passed away a few years ago because the treatment didn't have the optimal response. So from then on, and since always, I was thinking what I can do to help them, even if I'm not going to provide direct clinical care, I can still contribute to the field via research and via some sharing of our findings. I think some of you might not be very familiar with bone marrow transplantation. So there's a very interesting history from World War II atomic bombs. You know, US threw 2 atomic bombs in Japan, Nagasaki and Hiroshima. And then in the Cold War, the NIH started research to find a cure to people who have been exposed to lethal dose of radiation. They tried to build an animal model in mice, and they kind of give the mice lethal dose of irradiation. Then they get some spleen cells from another mice and inject to the mice get exposed. So the mice kind of rebuild their hematopoietic system. So this has inspired some clinicians, one of which is the father of bone marrow transplant, Dr. Thomas. Dr. Thomas is from Texas, but he received training in Colombia. he built his dog models using bone marrow transplantation. Then he moved to Seattle, and we have read so much articles published from Fred Hutchinson Cancer Center during my trainings in bone marrow transplant. So we call them the Seattle group. We all say in our journal club, what are the Seattle group's latest publications? It's the same thing in Paris and in China. So he has started there. And Dr. Eliane Gluckman was herself a legend. She completed his doctoral training in France, but she went to Seattle in 1974 to do bone marrow transplantation with Dr. Thomas. And when she going back to Paris, she started her bone marrow transplantation in Paris. She's Jewish, and it's not easy for a female clinician and to start a career in Paris at the time. But she's very strict. She has become a legend when I was there in her service. It was in 2008 and 2009, and she has been very strict to her. And there's a story that when she was hospitalized herself for cancer, she go downstairs to see her patient. She has more than 8,800 publications and have an H factor of 115. I think that's phenomenal. So she introduced me to her lab. She was current president of European School of Hematology, and I get involved with them. And one of her colleagues told me we need some clinicians with experience in R programming. So then I started R programming. And she encouraged me to apply for the master's degree there to do clinical research. If I had received the fellowship at the time, I could have started my outcomes research 8 years earlier than now. But I think the life is indeed a cycle. I come here and continue to do my research. So that was a long story. So bone marrow transplant is something initially developed to make people recover from lethal dose of chemotherapy and radiotherapy. Then people discovered that using blood cells from the donors can have an even stronger impact because the reactive T cells could attack the cancer cells in the patient, which could offer a better survival outcomes. So there are two types of transplantation. One is called allogeneic. That means you take some stem cells from patient, store it, frozen it, give patient a very high dose of chemotherapy or radiotherapy, and then you reinfuse the stem cells into the patient for them to recover. And the other one is, we call it allogeneic. That means you get the stem cells from someone who is matched to the patient, but not identical. Then the patient will undergo a chemotherapy to clear the cancer cells, and the cells from donors will rebuild the blood, rebuild the hematopoietic system. It's a very interesting and fascinating process, after which the blood types will change. So what we have observed in the trend in the field of transplantation, we now see more and more patients, especially the older patients, became transplant recipients. About 10 years ago, when I started in this field, when we have a patient who is 40 or 50 years old, we will say, oh, what is his comorbidity? What is the comorbidity score? Because chemotherapy and transplantation all comes with very high toxicities. If the patient are not fit for chemotherapy, they can even die before their cancers relapse. But on the other hand, you have the cancer. So if we don't treat them aggressively, they can die of cancer as well. So this is a very fine balance every clinician to make sometimes hard decisions. With the help, with support, with advances in supportive care, now increasingly bone marrow transplantation has been performed in very old patients. And I just read an article looking into outcomes of the transplant recipients who are 70 years old. And we will see this thing is going to happen even more. So we will see more and more transplant patients, they already have pre-existing chronic conditions like diabetes, like hypertension, like lipid disorders. And on the other hand, because survival care has much improved, so the patients now they live longer. Patients can expect to live up to their 50, 60 years old. So chronic medication adherence is really a huge problem in this small group of patients. So what we know about their adherence? Answer is we know very little. There are articles using only six patients looking into their adherence and even get published and cited. I need to admit they are very rich clinical data and the method has been very rigorous. But what the external validities of these 6 patients, how can they extrapolate it to the greater population, thousands of patients, it's unknown. Some research using self-reported adherence measures and find a very wide range of adherence. It ranges from 5.3 to 67%. People are not adherent even to their life-saving cancer drugs, let alone chronic drugs. So this comes from our study. We use a Truven database and identify the patients who undergo bone marrow transplantation and looking into their adherence and persistence over the time period up to 3 years. So it's very standard method. I think all of us are not unfamiliar with this method. We allow 60 days gap when we're looking into persistence. And for the adherence measures, we divided every 6 monthly period. So up to 3 years of follow-up, one patient can contribute up to 6 measures of adherence if they are persistent. And then we use a number of covariates from the baseline period as well as the treatment-related period. So the timeline like this, the patient with chronic conditions get identified in the baseline time period. They are required to have a diagnosis of diabetes in addition to 2 prescriptions of 2 diabetic oral medication to be eligible to enter the cohort. And the matched patients are the patients who only undergo chemotherapy without bone marrow transplantation. And they are all propensity score matched. And then there's a treatment period from the diagnosis to the day of transplant. For those in the unexposed group, because they did not undergo chemotherapy, they undergo bone marrow transplantation, so we match the same day and assign a mock transplantation as a proxy index date for the control group. And then there's up to 3 years follow-up period, and their adherence are measured in a 6 monthly period. This is a sample size for our study. We identify the patients who undergo allogeneic transplantation, those who undergo autologous transplantation, and those who are matched to these patients but did not go transplantation. They are matched by diagnosis, age, gender, etc. And in the end, we find a large number of patients with diabetes, hypertension, and dyslipidemia. So the last line is the final sample size for our study. They are 1 to 3 matched without replacement, and all patients get up to 3. All patients get 3 matched chemotherapy alone treatment groups.
Quick question, please.
Sure.
Go back to that slide. If they had both diabetes and hypertension, or any 2 or 3, how would they group?
So they can enter both if they have 2 conditions, and the baseline diabetes, dyslipidemia, and dyslipidemia and hypertension status are fit into models by that way.
And so where would they be in your graph?
They are in the final model, but a patient who have more than 1 chronic condition can enter both.
Thank you.
Here's the result. You can see the result of persistence on your handout as well. And we can see there's a number of risks. And persistently, patients who undergo transplantation had poor medication persistence, as we can imagine. And the difference are statistically significant. And when we look at 6 monthly period adherence throughout the follow-up time period, we can also find there's in several groups the difference are significant using generalized estimation equations, because a patient can be measured multiple times. So we use this model to account for multiple measures in the same patient. And we can see here, after transplantation, there's a drop in adherence in the transplant patient, understandably, in most of cases because they are not doing very well after transplantation. But as time goes by, they have even higher adherence based on the means. We think this is possibly going to be a healthy survivor bias or healthy user bias because patients who get discontinued treatment will be dropped out over the follow-up period. So what are the predictors for medication non-persistent non-adherence? We use the COX model to account for time to failure. So from time of transplantation up to the discontinuation of the treatment. We find quite a persistent pattern. So transplantation is definitely an independent factor for discontinuation of the medication itself. But we also find the baseline adherence is adherence in the 6 months baseline period before the cancer diagnosis. It's also a huge predictor for medication adherence. If a patient had PDC, percentage of the drug days covered more than 0.8 at their baseline, so they are less likely to discontinue their treatment after transplantation. In addition, we find depression and nausea, vomiting, and diarrhea is also a factor that could cause drug discontinuation. Using a very similar approach, we use the GE model to assess the independent predictors for non-adherence in cancer patients. Because these groups, they are not balanced because of differential attritions across cancer patient and the control group. So the result need to be interpreted with caution. We can find that younger patients are less likely to be adherent as a lot of studies. In addition, we find in the two subgroups, malnutrition is a factor that can cause non-adherence in the patient. All these conditions identified using the ICD code, diagnosis code, and procedure code. For the graft-versus-host disease status, we use both the medical history used to treat GVHD in addition to graft-versus-host diagnosis to make the identification of the condition more specific. And all these time-varying covariates are collected using the 6-month period, the same as the adherence measures, and they are repeated measures throughout the follow-up period. Here's our conclusion. So we find there's a large number of patients who are not adherent or not persistent to their chronic medications. And we also identified a number of predictors for non-adherence and non-persistence, including younger age, depression, malnutrition, and gastrointestinal conditions. We believe these findings could have huge implications clinically. So first, we not necessarily do nutrition status and depression screening before the transplantation. I think this is something to identify even before transplant, so we can identify the patients who are more likely to have these adherence problems. Second, we find the patients are not adherent to their treatment after transplantation. Even after they undergo such expensive labor-intensive treatment, they can still die with complications from their chronic medication. That would be a waste of resource and a waste of health resource because we want them to have healthy lives and we want them to live longer. So this result can help the clinicians to guide the patient throughout the follow-up period. My second research is on identifying the patient with high need and high cost patient. So this result stemmed from the first study because my mentor Greg asked me to measure the patient visit with primary care providers. Because from our experience with other chronic conditions in general population, patients with frequent primary care visits are more likely to be adherent. And when we fit the primary care visit into our model, we find the results are very hard to explain. So then I think maybe measuring primary care visit is not enough. If the patient has been admitted, so he cannot go to the outpatient care. If a patient is receiving specialty care, as we always did, hematologists like to follow the patient as long as possible until they can afford it. So it's a joke. So we all like our patients, and we like to follow them and to see them live happily and live healthily. But there was a time the patient will be transferred to their local health facilities. It's not necessary they will be followed by a primary care provider or specialist. If they are finding their medications in their specialist, then measuring the primary care visit is not enough. And in addition, for the patient who have frequent emergency room visits, it's also something going to impact their adherence and persistence. So then we look into the patient journey. So we look into their health service use as a whole. We don't want to assess as a traditional approach. We use a variable-based approach to assess, so what's the implication, what's the predictors for primary care visits, what are the predictors for hospital admissions, what are the predictors for emergency room visits. We want to model them as a whole. So after some literature research, I find latent class analysis would be a still appropriate approach to address this question. So all the 5 variables are considered simultaneously as a whole. So we model we call them hospital admissions, ER visits, length of stay, primary care visit, and specialty visit as indicator variables. So they are indicating there's a latent class in the patient. And using the statistical models, we will be able to identify the exact latent class membership for each individual patient based on the probability they will be in each group. And once the latent class membership has been identified, we will be able to use the variables selected to predict their class membership using models.
Yeah. Question, what's your latent class? What's your latent variable?
Latent variables are categorical.
No. What is your latent variable? Like, is it high need?
We don't know. So we first it's like a clustering problem in machine learning. So we store the patient in, fit the model, and based on the closeness of each other, they will group in the model, in each groups. Then we use our clinical knowledge to interpret the results.
No, I understand what, I'm familiar with latent class analysis. I want to try to wonder how you selected hospital admission, ER visits, hospital length stay, all those indicators of latent variable.
Oh, yes.
So I'm just trying to understand what latent class is.
So I need to show you the study design scheme. So the patient will be selected based on the baseline transplantation. Then we have an observation period up to 1 year after transplantation. So this is the time period we call the observational period. Is a time period their health service use, health resource utilization will be measured. Then all these patients must have 2 years of continuous follow-up, so they are already long-term survivors. And we use the 2nd year's data to assess whether the classification are meaningful. So it's like a validation process.
I don't know if I'm being clear.
What concept is your latent construct?
Yeah, the conceptual basis of this. That's all I'm interested in right now.
Yeah, so the conceptual basis is their health utilization patterns.
Okay, so the latent class, the classes you're looking for, the latent variable or concept is just need or utilization.
Yes.
Okay.
Because we are looking for high-need patient in the beginning. So our primary exposure is still, it became latent class membership. We have 2 group of patients, 1 group of patients receiving allogeneic transplantation, and the other group receiving autologous transplantation. and we are looking into their health service use. We try to group them into distinctive health service use patterns. And we also looking into healthcare expenditure to see whether high users are associated with high cost health service. So the variables are empirically classified. We class each variable as non-users, low users, and high users. If the patient have less than one primary care visit on a monthly basis, but non-zero, they are low frequent users. If they have more than two special visits, then they are high users. The same thing applies for emergency room visit and admissions. So all the indicator variables are grouped into three categories: non-users, low users, and high users. Then comes a very interesting modeling part. So this is a statistically based modeling. So imagine you have a two-dimensional graph, and all patients represent across there. Then using models, you can group the patient based on the similarity and the closeness based on these indicator variables. So imagine we are just doing the same thing with 5 dimensions, and the models will tell us what would be the likelihood the fit statistic is. So the right figure shows that we call it an elbow curve. Because we don't know the number of the latent class, so we model them from 1 to up to 20, for example. Because we can see the lower BIC base indicate the better model fit. So there was a time when the model became increasingly complicated with the number of the latent class increase. Then the BIC can decrease and increase again. So we applied our parsimony principles, model interpretability principles, in addition to all the fit statistics. We find that the 4-class models is the most easy to interpret, but also have clinical meanings.
One moment, please go back to that pre-crafting. One, I want to commend you. This is the first time I've seen that. I know SAS has a hitting, batting average example, but you're the first one I've seen in PSOP use that graph on the left, and this is almost easier for me to understand that hitting, batting average. But is there anything on that graph in the left that really pops out you want to tell us?
The left.
I already had to interpret for this.
Yeah, so the different colors reflect one point represents one patient, and the different colors and the lines shows the model fit. This is not the final model, but one of the figures. So they are grouping the patient into even 20 groups based on the best model fit. But we decided to not use them because there could possibly be an overfitting. They are dividing the patient into clinically meaningless groups. So in the end, we decided to use 4 latent groups.
Jifang, since we're asking questions, can you go back one more slide? No, the other back. Yep. What are the implications of using an indicator variable in a latent class analysis that is conditioned on another variable in the latent class? So you can't have length of stay unless you have admissions.
Yes. So that's because the length of stay and admission event, they are interrelated, and also they are representing 2 dimensions for the patient in-service use. So that's the reason we decided to include both, because you can have 5 different admissions with only 1 or 2 days of length of stay, or a very long length of stay with more than 30 days, which could also affect the number of days a patient can visit outpatient service. So from a broader sense, all these 5 variables, they are interrelated. So because when you're admitted, you cannot go to outpatient services. So we decided to model them simultaneously.
Yeah, but you could have admissions and outpatient visits. Those things certainly are correlated, I agree with you, but you cannot have a length of stay without an admission. So it is inherently necessary for you to be admitted to the hospital for you to get days in the hospital, right?
Right.
So those two things are certainly related to each other, and I'm just wondering what those implications are in terms of the clusters that you will see in your latent class analysis, because they have to go together. They absolutely have to go together.
So I think the implication is for those patients with 0 length of stays. So the patients who are not admitted, the probability of a length of stay is definitely 0. But the patient admitted, they can be very close to 0 up to the infinite, but it will be non-zero probability. So this will be a distinction. But then we already make the model, but this is a very important point. So these are the item response based the probabilities of each group of patients, because we divide into 4 groups, and the probabilities of responding to each of these items based on the model. So we group them into 4 groups. Group 1 is specialty care dominant groups. These patients are very unlikely to be admitted. You see they respond very likely to close to 1 to be non-users for hospital admissions. And the second group is intermediate users. They have low use of inpatient care, but they have also some use of outpatient care. The third group is primary care dominant groups. So again, they are very likely to be admitted because they respond almost 1, but to be non-use of inpatient service. But they reported somehow more primary care visit compared to specialty care visit. And the last group is our focus group, because they are very likely to be admitted and they are high users for emergency room visit. And both, the pattern is very similar in the allogeneic group and autologous group. And they only represent 17% in the allogeneic group and 3.5% in the autologous group. So the group 4 is a group we want to identify. Those are high user group.
Dr. Tishan has a question.
Yeah.
Dr. Crawford has a question. She was just afraid that she was asking too many questions.
IRT, what did you do? How did you say item response theory based probabilities? It's a simple question. What technique did you use?
It's just I use SAS, and there's a SAS macro which enables me to do latent class analysis.
Based on item response theory?
Yes.
Oh, thank you.
So they are all model. They are all model-based clustering methods, and they calculate the likelihood of patient of responding to these different categories. As if you are asking a patient a question, what was the probability of him or she answering, I'm the high user group, I'm the low user group.
Thank you. For Dr. Tishan.
Yes, thank you.
So this is a means of health service used in different groups. So we see a very distinct health service use pattern. The yellow lines represent the very high user group. So there are very high users in terms of inpatient care, emergency care visit, and the gray lines represent the primary care dominant group. So they have very low healthcare utilization overall, but they are very high users of primary care. And we also have intermediate group and the specialty care group. So these are the results based on the first year of transplantation. So unsurprisingly, because we use this data to generate the latent class membership. But in the second year, we see the pattern persists. The identified high user groups remains to be high user groups. And those patients, like the gray line, the patient with dominant primary care visits in outpatient settings continue to receive a lot of primary care, and the results are statistically significant. The same thing applies for autologous group as well as allogeneic group.
What do you mean the results are statistically significant? Across each of these categories?
No, we can't do multiple testing, so we do.
So what do you mean? So what does that mean?
That means at least one group is different from the population means.
Thanks.
But we we can visually see that high user groups stands out. Even there's also an impact of regression to means in the second period, but the results are still different. Then we look into their health service utilization, looking into the economic dimension. We're looking into their total health expenditures in the first year after transplantation. We see that the high users, the driven power behind their high user is from inpatient service use, in addition to outpatient service use, but to a less extent. The high users, this is their monthly total health cost from a societal perspective. And these are significant both in the first year, but also in the second year. We can see the result is still significant for the high users in the second year. And that means our class membership, latent class membership, they are indeed meaningful and they are persistent and they are very good in distinguishing the patient with different numbers of service use and healthcare expenditures. The same thing applies for the autologous group. Again, we see that there's no difference in terms of prescription drug costs, but the difference in total health expenditure has been driven by the inpatient care and outpatient care. And in the second year after transplantation, the difference between latent classes are still significant. So what's the sensitivity and the specificity of this latent class membership? We find that as many of studies, the high users have been the power driving up the total health cost. So in the allogeneic transplantation, top 28% high users spend 63% of the total dollars in the whole group. And the top 5% patients spend 32% of their total health expenditures. So these are not small numbers. As I have explained to you, a patient can cost more than $30,000 in hospital each month. So if we can identify the patient in advance, maybe we can using a tailored management program to reduce their comorbidities and to reduce their health expenditures. And we also see the percentage of the high users in each group. So we first find there's a very good specificity there, because in the fourth group, which is the high user group, up to 70% of patients are high users, and up to about more than 20% of patients, they are top 5% users, which shows this latent class analysis has very good discriminatory power in identifying patients based on their health service use. So the differences are not that pronounced in the autologous transplantation, because autologous transplantation is much less intensive compared to autologous transplantation. But still, we find that the healthcare expenditures have been driven by the intermediate use and high user groups, because by combining these groups together, they represent more than 66% of the patients in the top 5% spending group. So then we use a logistic regression model to assess what are the predictors, baseline predictors, that could predict the patient membership after their transplantation. We find that the graft versus host disease is a predictor for the patient staying in the high user category. And also the 100-day transfusion status, whether the patient receives a transfusion in the first 100 days, is at the borderline of significance. We believe that when the patient has a requirement for transplantation, that's an indicator for their delayed recovery after bone marrow transplantation. When a patient has delayed recovery, then when their body cannot make enough blood cells, they are requiring transfusion, they are very prone to infections, and which is also indicator that the donor's blood cell does not grow well in their bodies. So we identified one strong predictors for being the high spending, high use group. So what are all these implications? I think it has implicated to the patient, because the patient understanding the care pathway of the patient is essential in designing the post-transplant care. And also, from increasingly the patient receive transplantation, and then they are not likely to be followed in the transplant center. They will be followed in the local facilities. So how to identify patients who are more likely to be requiring high service use and identify them and keep them in the transplant facility, which have a higher quality of care in general, would be important in their in improving their patient outcomes. Also, we have identified some factors that could affect the healthcare spendings. So we know the health resource is limited and a small number of patients is using a lot of healthcare resource. If we can reduce the healthcare spendings in this patient without compromising their quality of care, so we could use make more patients undergoing transplantation a potentially life-saving process. So I would like to thank the department for giving me access to the children database and allow me to use this data. I would like to thank my mentor, Dr. Udesco and Dr. Khaled for the guidance. And also I have some collaborators from UI Health. And also thanks this research has been supported by my FV fellowship. And I would like to thank to my supervisor, even she's not here, to allow me to make time to the campus to give the presentation. Thank you very much.
I have a lot of questions, but I don't want to monopolize the question and answer session. So
He even took my pen to write it down.
I'm going to start with the latent class analysis, which I think is very, very cool. However, I want to challenge you as to whether, stop right there, that's where I want to go, the next one down, whether or not it's necessary, right? What you would contend with a latent class is there's, as Ernest was saying, some construct that these things together tell us something about. And then it may help to inform whether people have to stay in cancer centers or go somewhere else. I don't know that your latent constructs or your groups help at all. Isn't it just hospitalizations that's driving this? Like, isn't it enough to tell me that, oh, I've had more than two hospitalizations. I'm a high user, because that's really what's differentiating your groups and your latent classes. So is trying to put those 5 categories together really making us twice as smart by half when we could have just looked at hospitalizations?
It's because before conducting the latent class analysis, we don't know whether inpatient admissions is a strong predictor for healthcare use or health spendings. It's something we have after the latent class, then we know maybe inpatient admission is the main driving force for the patient. And also, one thing I need to point out, we need to differentiate so some risk factors that are modifiable and some risk factors are not modifiable. Some inpatient admissions are avoidable, but some are not avoidable. With claim database, we are unable to differentiate what are wasteful care and what are necessary care. Whether these patients who are high users are receiving life-saving care or they are just wasting health resource. It's something that we can't answer at the moment, but using latent class will give some signals showing at least there are different health patterns. And although we cannot differentiate what are difference of patients who have low users, but who prefer to use primary care and those small groups who prefer to use specialty care, but at least we know these patients, they are different. And what are driving cause, what are reasons for their preference, we still don't know. But I think this is the first study using latent class analysis, and it gives something to the field, although not definitively, although we are lacking clinical meaningful information, but I think there are some positive points in there.
Can I just jump on that point? So one way that latent class analysis is typically used for baseline characteristics and identifying the constellation of patients or individuals that have different covariates.
Yeah.
So one approach to this that might be more meaningful is to look at what types of clinical variables, what groups of people there are based on clinical variables.
Yeah.
Because these latent classes are based on outcomes.
Yes.
Right? So you can look at the constellation of clinical factors, clinical profiles of patients, and then see how they consume resources.
But that was part 2 of this, right?
So there were two different approaches. The first is one-step approach. That means you group the outcomes in addition to the baseline characteristics and fit them into a latent class analysis. So we know the model has been based on there. And I use a second approach, first to group the patient based on their outcomes, and then use a logistic regression model to see what are the predictors for latent class membership. There are studies mostly from psychology and behavioral science that use latent class analysis, and I couldn't say which one-step approach or two-step approach, which one is superior. But in our analysis, it will allow us to looking into the outcomes without looking into the potential predictors, and using a separate approach to identify the main factor that have the most significant impact on the latent class membership.
But to me, you're right. It depends on what decision you're trying to inform. To me, what would be actionable or more actionable is you get a patient that's being considered for transplant, and then you have they have a set of characteristics, and then if you had done a latent class analysis based on their clinical baseline characteristics, you could identify those that are at highest risk for resource consumption. Because the way that you group them now, as you said, I can't tell if those are appropriate or not.
No,
right?
This is a problem of latent class because they are latent, so it's not observable. We can only observe through the indicator variables. One limitation to my study is that using a claim database, we are lacking crucial information from what's a donor match, what's the HLA matching status, what's their ABO blood type matching status, what are the cytomegalovirus status that could impact their outcomes. Without information on all these variables, I don't think grouping patient age, gender, or health stand height would have a major impact in predicting the patient outcomes. So it's something we may need to validate in an external cohort of patients.
Okay, just clarify that. These figures. Are you showing that membership changes if you repeat the latent class analysis?
No. The first figure is the first. So we use 101 days to 365 days to determine the latent class, and then the second year is purely descriptive. So we have after identifying the latent class, they will be compared to see whether the class membership has been persistent into the second year. And the result is that high users are very likely to be high users in the second year, which also should give some more confidence into these classifications are indeed valid and clinically meaningful.
I'll ask a quick question about the other study. Your Kaplan-Meier plots, how do half of the people discontinue the medication at day 0?
Yes, many people have discontinued the medication during the treatment time period. It's a time period from their diagnosis to the transplantation or the mock transplantation for those in the reference group. We did the testing for proportional hazard assumption test, and we find that the proportional hazard is valid.
Yeah, but you're saying that half the people quit the drug before you even started to measure whether or not they're adherent.
We need to assume that the impact on the reference group and the treatment group, they are similar. Because of the varying time in the treatment, it's very hard to model the patient. Some patients get transplant after 1 month of diagnosis. Some patients have, in our study, we include patients who receive transplantation within the first year of their diagnosis.
So within this variable time, it's really hard to know because the patient can quit at any time, and the follow-up period is different across the subjects.
So somebody who had their transplant 6 months out, if they stop their statin 2 days after becoming eligible, you're calling that person not adherent.
No, in adherence measures, they must be persistent.
But then how come 50% of the people drop off? Yeah, but this is.
But these patients are not being used in the adherence measures.
But they're being used in the persistence
Yes.
measures.
That's why I said that in the adherence measures, the patient in the treatment group and patient in the reference group, they are no longer balanced because there are more patients dropping out in the transplantation group, and the result need to be interpreted with caution. But I think the analysis on the medication persistence are still valid because first,
How much of the persistence drop is like because of dying?
we don't know. We don't know. We can only say that we sense the patient when they disenrolled from health plan, but as all the studies have proven, it's very hard to know what's the exact reason for the dropout. And they may be switched to the injectable medication, although we adjust for injectable diabetic medication in our model, but it's very hard to know whether they are died, they have switched to other type of treatment, or they stopped. We can just say they stopped buying drugs.